So what is the role of an immunosuppressive agent? Immunosuppressive agents are used in various conditions, especially autoimmune rheumatic diseases and organ transplant cases where you might need immunosuppressive agents to go on for lifetime. Basically, if we talk about the immune system, it is going to target a couple of pathways, that is the adaptive and the humoral immune system. So we will not go in much depth of it. What we need to know is that this immunosuppressive agents need to be dosed in such a way, because it is having a very narrow therapeutic window. We have to try to maintain it range in that window. Otherwise, there are chances of having a lot of side effects. And if you are underdosing, you might not achieve the aim, that is to give a proper immunosuppressive effect. So this is a slide just showing that there are T cells and B cells in the body. So T and B cells are basically the cells which are responsible for the cell-mediated immunity. And when a T cell presents an antigen to a B cell, which leads to ultimately the formation of antibodies with the help of plasma cells, these antibodies are then going to help with the adaptive immune system, that is the humoral response, which are then found in the extracellular fluid. So you find a lot of antibodies, complements, extracellular peptides, which are there in the extracellular fluid, which is basically holding the humoral immune response. This is just a slide to give a brief overview of some of the classes of immunosuppressive drugs. And as you are aware, in 8 minutes, we are not able to completely cover all the classes and the names. I have just displayed it for the attention and then just a brief overview. We'll go through quickly few drugs which we commonly use, and what are the common effects and side effects and the indications of such drugs. So methotrexate is one common drug, which is an anchor drug which we use in rheumatoid arthritis. Many of you might not be aware that the inventor or discoverer of this molecule is an Indian doctor, Dr. Subbarao. He's from Andhra Pradesh. And he is the one who discovered this molecule and is kind of the anchor drug for a lot of rheumatological diseases, including rheumatoid arthritis, psoriatic arthritis. We use it in Takayuki arthritis, a lot of myositis. There is a confusion regarding whether to go for the pyramid approach, low dose, up titrating it, or go start with the high dose and go down. So we'll come to that. Most important thing to remember for all medical officers is it's a weekly dose. What happens is in elderly age group, when patients are staying away from their kids and they stay alone, 15 milligram tablet comes in a strip of 10. So what happens is they at times take it daily, and then they end up in a trouble and in a very bad bone marrow suppression state, and those are the complications that we usually see. So it is a weekly dose, not to be taken as a daily dose. That's one of the most important things. Most common side effects are nausea, vomiting, oral ulcers, which we see on a routine basis. Again, a point to remember is that this teratogenic drug should be avoided in pregnant females. You need to counsel it well in advance, because usually rheumatoid arthritis patients are young females. So we need to tell them that stop this molecule 3 months before you plan to conceive. And whenever you see patients with methotrexate overdose, we treat it with leucovorin. So this is the graph which is showing that usual dosing is there's a lot of confusion regarding. We see a lot of patients who are being treated by orthopedicians in the periphery, and they give very low dose, minuscule dose, 2.5 milligram, 5 milligram, which is not going to have any effect. And higher doses are used in chemotherapy. Usual dose which we use for arthritic part is usually ranging between 15 to 30 milligram. Next drug is leflunomide. The drug is again available in 10 and 20 milligram, depending on weight less than 45 and more than 45 kg, beside the dose. Earlier, there was a concept of loading. We used to load it 100 milligram and then, we went into OD dosing. But that concept is now no longer valid. There is no need to load this type of molecule at the onset. Again, common side effects, GI side effects are the most common side effects. Point to notice, it can also present with a very bad rash, which can present like a Steven-Johnson syndrome. And whenever a patient is started on a leflunomide type of molecule, if the patient is coming with skin rash in few weeks, always beware that this can be a culprit molecule and we need to stop it. Again, it's a teratogenic drug, and it has strong interactions with drugs like warfarin, and it can be eliminated with the help of cholestyramine. Another drug is azathioprine, which we use a lot in cases of, say, myositis, in lupus nephritis, transplant rejection for prevention of that. We use it in vasculitis. One important thing is that there is an enzyme which needs to be studied, PPMT. So that enzyme, when it is deficient, there are high chances that the patient might undergo a very strong bone marrow suppression with it. And if that happens, it can ultimately lead to the death of the patient. point to note is that even if the patient is not PPMT deficient, we have seen that at any point of time during the course of the treatment with azathioprine, if the patient suddenly develops cytopenias, you need to consider that the patient might be having azathioprine-induced marrow suppression and stop the drug. So that is one very important point. The good point is it's a safe drug during pregnancy. Coming to another drug, mycophenolate mofetil. It's a drug used in multiple conditions like lupus, lupus nephritis, myositis, vasculitis. The most important thing is it is available as two formulations, mycophenolate mofetil and an enteric coated tablet. Now, mycophenolate mofetil is the usual drug which we start with in most of the cases, but most common side effect is diarrhea. GI intolerance is one of the biggest side effect, and then in such situations we stop the mofetil preparation and shift over to the enteric coated preparation. Again, the most common side effects are that there is a strong chance of reactivation of infections, and there is a protective mechanism in Pneumocystis jirovecii, which is very strange, but yeah, I mean, it's shown to be slightly protective in PCP. However, secondary infections with CMV and zoster is quite frequent. The other drug is tacrolimus, which is again most often used in cases of organ transplants. I just copy pasted it from the up to date. Usually, the nephrologist and the hepatobiliary team who deal with the organ transplants would be better to comment on the doses. The last instance where I was involved was in 2011 when I used to work in the Institute of Liver and Biliary Sciences. Occasionally, we use it for rheumatoid arthritis. That is the dosing is 1.5 to 3 milligram in such cases. The most common thing is that you have to monitor all the blood parameters, especially the marrow suppression and it's a drug which need to be monitored from nephrological point of view as well. And nephrological and neurological toxicities are something which we need to look out for. Other drug is cyclosporine. Occasionally, we use it for HLH, that is macrophage activation syndrome, and under certain conditions in certain other autoimmune conditions as well. Most commonly, what we need to know apart from the GI side effects is this can cause gingival hyperplasia and hirsutism, and it is a cyclosporine, as is the case with other agents. Cyclophosphamide again is it's one of the most potent immunosuppressive agent which we use for lupus nephritis and other vasculitis like GPA, LPA, and Churg-Strauss syndrome. There are different regimens. I will not go into depths of it. Most common side effect is nausea. A very strong nausea. We need to give pre-medication before starting cyclophosphamide. Another important thing is we need to maintain very good hydration. So we need to give good amount of IV fluid after giving cyclophosphamide. We need to counsel patient for hematuria and bladder toxicities. And in males, we recently had a male young lupus who we started on cyclophosphamide, and he is brother of a surgery resident in LG Hospital, and we had asked him to get his cryopreservation of sperms done because it's a gonadal toxic agent. So that was done. In females, we can use GnRH Aralox before starting this type of medications, and we also use Mesna for the cytoprotection. There are other drugs like JAK-STAT inhibitors, tofacitinib and baricitinib, which we are all aware as we have used it quite often in the COVID, but it has been usually used in rheumatoid arthritis, psoriatic arthritis, myositis, and juvenile idiopathic arthritis. Steroids is one thing which probably most of the clinical disciplines would have used. It's one of the most commonly used immunosuppressive agent in organ transplantation and in all autoimmune diseases. Most common side effects which we all need to be aware is that the sugar levels can go up and down, blood pressure needs to be checked regularly, acidity, ulcerations, weight gain, increase in hair growth, secondary risk of infection, bone loss, cataract, glaucoma. These are the most common things which we need to be aware whenever a patient is on steroid type of medications. I will not go into depths. Biologics, there are a lot of biologics. There is tocilizumab, which we have used in COVID. Infliximab, again, we have used a lot in COVID, but these are primarily molecules which are designed for use in a lot of immunological conditions and rheumatic diseases like rheumatoid arthritis. In short, to conclude, this duration is quite low to discuss about the immunosuppressive agent. The aim of this talk was to just initiate a few thoughts that the common side effects that we see with this type of agents are secondary infections, which we need to look out for, apart from the marrow suppression. So CBC and certain specific molecules require monitoring for transaminitis as well. So with that, I would like to conclude this.